will be giving us a presentation on the management of a 3-year-old with uniocular retinoblastoma. Sit back and benefit from new knowledge. Thank you.
Okay. Thank you very much for inviting me to do this today. My name is Dr. Gloria Oduware. I'm a senior registrar in University of Benin Teaching Hospital, Benin City. I want to appreciate the YOF executives and members and all my teachers at University of Benin Teaching Hospital. Today, I'll be discussing the management of a 3-year-old with uniocular retinoblastoma using the following outlines. Retinoblastoma is the most common primary intraocular malignancy of childhood. It's a neuroblastic tumor that arises from the retina, and it accounts for about 3% of all childhood tumors. The incidence is about 1 to 16,000 to 1 to 18,000 live births, or in some literatures, 11 per 1 million children under 5 years. There's no sexual predilection, and also no particular race is affected. The diagnosis is usually in the first year in familial and bilateral cases, and 1 to 3 years in sporadic and unilateral cases. Approximately 90% of cases are diagnosed before 3 years of age, and the onset later than 3 years is rare, but it can occur in some individuals. The average age of diagnosis is usually at 18 months. Then 40% usually occur bilaterally, that's about 1/3, 15% with positive family history, 85% new germ mutations. Then there are 60% usually unilateral, and out of that unilateral, 15% could be genetic out of the unilateral ones. Then 60% are also, when it comes to being sporadic or familial, sporadic means occurring at very inconsistent intervals. 60% can occur that way. And 40% are familial, which means that they usually run in the families. Then worldwide, 8,000 cases present yearly with 89% in medium resource countries with a survival rate of 30%. In UK, 40 to 50% of patients are new cases are seen per year with a survival rate of more than 90%. In the US, 200 to 300 cases are seen per year, while in Nigeria, 339 new cases are seen. There's a tumor suppressor gene that mutates, and when this happens, this can predispose one to having retinoblastoma. The name of this gene is the ROB1, and over 900 different mutations have been reported to date. Now, there's something called the Knudson-2 hit hypothesis. It's very essential in understanding the genetics of retinoblastoma. In this, the 2 complementary mutations are essential for the development of hereditary and non-hereditary forms. So you have to have 2 separate mutations. Now, the first hit for the heritable one happens in all the body cells, while the first hit for the non-heritable happens in just the somatic cells. Now, for the heritable or hereditary type, there has to be a second mutation which occurs in the somatic cells, and this results into a multifocal or bilateral lesion. While for the non-heritable ones, you have the first and the second mutations occurring in a single retinoblast, and that is why you have unilateral or a unifocal retinoblastoma. Now, concerning as regards the genetics of it, there are 3 types: the hereditary, sporadic, and the chromosomal. The chromosomal usually results from deletion of band 14 of the long arm of the chromosome 13 of the ROB1 gene. Then the sporadic shows, for the sporadic or the non-hereditary, the tumor is usually unilateral, is non-transmissible, and does not predispose the patient to second non-ocular cancers. Now, 90% of children with unilateral will have the non-hereditary form, and the non-hereditary form usually presents at a later age. However, 15% of those unilateral cases usually have germline mutation. Now, the hereditary is also seen in 40% of cases. The mode of inheritance is usually autosomal dominance with 90 to 95% penetrance, and one of the pair of alleles of ROB1 is mutated in all the cells, like we said before. For the hereditary, it's usually multicentric and bilateral, and there's a predisposition to development of pineloblastoma, and this is an osteogenic sarcoma. When there's a pineloblastoma, we call that a trilateral retinoblastoma. Other tumors that can develop include the osteosarcomas, soft tissue sarcoma, and the melanoma. Now, into our discussion proper. We're discussing the management of a 3-year-old with uniocular retinoblastoma. Management of this patient will involve clinical manifestations, which include both the history and the clinical findings. Now, proper examination of this patient, investigation of this patient, and certain treatment options that are available, including counseling and follow-up for this patient. Now, the most common presentation is leukocoria. That's the white pupil, or what we call the cat eye appearance. This is usually noticed during photographs and family photos, or nowadays when we have a lot of smartphones, people take photos of their children, and this is usually noticed during those photos. So it's also important when you are assessing these patients to ask for some family photos to confirm their diagnosis, especially when the cat eye reflex is not so prominent. Now, also you may have 20% of cases present with strabismus, which could be either esotropia or exotropia. They may also present with secondary glaucoma, which may or may not be associated with ophthalmos. Then anterior segment invasion may occur, and this is usually manifested as a red, painful eye. There may also be hypopion or hyphema. Okay. Then patients may present with orbital inflammation here, mimicking orbital cellulitis. So this may be like a masquerading syndrome. You may think that a child has an orbital cellulitis, but in reality, this child has a retinoblastoma. Also, proptosis is usually a sign of orbital involvement. Then other presentations may be unilateral mydriasis, heterochromia, iridis, vitreous hemorrhage, which all occur as a result of infiltration. Now, on examination, an indirect ophthalmoscopy after full mydriasis is very important. And when you're doing an indirect ophthalmoscopy using a binocular indirect ophthalmoscope, indentation is very important so as to see tumors that arise anterior to the equator. Also, wide field retina camera systems can be used in places where nowadays, due to our resource limited settings, we may find this difficult. However, with the advent of smartphones, there's a possibility of using smartphones with a special lens, that's 28D or 20D lens, to view the fundus. Now, sedation is often required, and we can give chloral hydrate syrup. This is usually given orally, 25 to 50 milligram per kg. In the absence of this, some centers use syrup, diazepam. Others may decide to use injectables like IM diazepam or even IM syrup promethazine to sedate the child. Then let us remember that both eyes must be examined. So in as much as this child has a uniocular retinoblastoma, we must ensure that we examine both eyes, because the other eye may just have the early stages of retinoblastoma. Then on binocular indirect ophthalmoscopy, we're likely to see an intraretinal tumor, which is homogeneous, dome-shaped, white lesion, which is often irregular, and with white flecks of calcification. Now, there are different patterns of growth as we examine. One pattern of growth is the endophytic tumor. It grows from the retina into the vitreous cavity. Then the exophytic tumor grows into the subretinal space, leading to retinal detachment. Now, in order to further examine this patient, it's essential for us to know how to classify the intraocular retinoblastoma. Now, there are different methods of classification. The Rice-Ellsworth, which is the first, and it's kind of outdated classification, only predicted the chances of saving the eye following external beam radiotherapy. Then later, the International Intraocular Retinoblastoma classification was decided to factor in intravenous chemotherapy as medical treatment progressed or medical discoveries advanced. Then the intraocular classification of retinoblastoma, which is the ICROB, is a modified IIRC, but differs mainly in groups D and E. We'll see that as I go on. And in 2006, the ICROB scheme was found to successfully predict the outcome of intravenous chemotherapy. Now, there are other modes of classification, but what we use commonly is the ICROB or the IIRC. Now, this is a table showing the IIRC classification, that's the mode of classification, and the ICROB mode of classification. For group A, the ICROB tends to keep it a little bit simpler. For group A, which is very low risk, there's tumor less than 3 millimeters in basal dimension or thickness. For the group B, there's the retinoblastoma more than 3 millimeters, okay? But the macular location is less than 3 millimeters to the fovea. The juxtapapillary location is less than 1.5, that is, it's less than 1.5 millimeters to the disc, is less than 3 millimeters to the fovea, and there may be additional subretinal fluid, which is less than 3 millimeters from margin. Now, group C, which is moderate risk, is when you have a retinoblastoma with subretinal seeds that are less than 3 millimeters from the tumor, vitreous seeds that are less than 3 millimeters from the tumor, or both subretinal and vitreous seeds less than 3 millimeters from the tumor. The group D, which is the high risk, is when you have subretinal fluids that are greater than 3 millimeters from the tumor, vitreous seeds that are greater than 3 millimeters from the tumor, both subretinal and vitreous seeds greater than 3 millimeters, meaning that these seeds have actually expanded, they've dispersed more than the moderate risk. And for the very high risk, you have extensive retinoblastoma occupying more than 50% of the globe, with neovascular glaucoma, opaque medium from hemorrhage in anterior chamber, vitreous or subretinal space, invasion of the postlaminar optic nerve, choroid, sclera, orbit, and anterior chamber. Now, these are some of the stages. This is a small equatorial tumor confined to the retina. Okay, then this is foveal tumor. This is a foveal tumor confined to the retina. This is another fundus picture showing a retinal tumor surrounded by a cuff of subretinal seeds. It's not very clear, but around here are the subretinal seeds. And this is another fundus picture showing diffuse seeding of this patient. Now, this is the last stage, the advanced stage, where you have a large tumor touching the crystalline lens, resulting in elevated intraocular pressure and expanded globe. Now, for the extraocular retinoblastoma, there's a staging called the International Retinoblastoma Staging System by Tada and colleagues, which was done in 2006. And for this staging, there's stage 0 to stage 4. For this also shows the clinical description of this patient. Now we see that for stage 3, there is a regional extension. There's overt orbital disease. So, and then by stage 4, you already have hematogenous metastasis to the CNS, and the CNS nervous system extension, which without any other site of regional or metastatic disease. Now, for the investigations, there's a simple investigation that one can do in order to diagnose retinoblastoma in this patient. A red reflex testing with a direct ophthalmoscope is a very simple test that can show leukocoria in that patient. And this can easily be employed in the community during community testing. And there's the examination under anesthesia is very important, usually done under general anesthesia. And the things we have to look out for general examination for congenital abnormalities of the face and the hands if this patient has. But usually for someone with uniocular retinoblastoma, we may not find this. However, in 15% of them, there are some germline mutations. So it's still good to examine this patient. Then tonometry to check for raised intraocular pressure. Measurement of the corneal diameter gives you an idea of the extraocular expansion that can happen following extraocular extension. Then anterior chamber examination with a handheld slit lamp is also important to look out for neovascular glaucoma, to also look out for anterior chamber bleeds as hypopion, hyphema in this patient, and also to then ophthalmoscopy, both the direct and the indirect ophthalmoscopy preferably, that can show a vitreous hemorrhage, and also looking at the retina can show the dome-shaped white lesion with multiple calcifications. Then it's also important to do a cycloplegic refraction, especially at the mild stages, and also for the other eye. And other relevant investigations, the orbitoocular A and B scan is also very important. For this, we are likely to find a tumor arising from the retina with areas of calcification. And for the A scan, you would see multiple high ultrasound spikes and some orbital shadowing. Then the importance of the ocular A and B scan is to evaluate the optic nerve invasion. It also can show extrascleral invasion and orbital invasion. It also helps to rule out differentials such as Coats disease and persistent hyperplastic persistent fetal vasculature. Sorry. Okay, other investigations, MRI, the magnetic resonance imaging and orbitocranial MRI. This does not detect calcification unlike the CT scan, and but it's useful in determining intraocular tumor size, and it's also useful in ruling out trilateral and intracranial disease. The tumor seen is usually hyper-intense on the T1 weighted MRI. Another investigation is the computed tomography CT orbitocranial. However, like in this CT scan, we can see areas of calcification here. We can see the tumor and areas of calcification here in both eyes, which is more in the right eye. However, the CT scan is discouraged in order to avoid ionizing irradiation and consequence of other non-ocular malignancies, especially in the heritable type. And then the other investigations that can be done, bone marrow aspiration, it shows a metastasis, CSF cytology, and genetic testing, which is 96% sensitive. Now, treatment of this patient will involve a multidisciplinary team of ophthalmologists, pediatricians, oncologists, nurses, geneticists, social workers, anesthetists, allied health workers, and the rest, including family members. And it's important to determine your goal for this patient. Is it to save his life? Is it to save the eye? Or is it to save the vision? So you can remember for goals of treatment is it 3 S's or 3 saves, either the life, the eye, or the vision. So this will guide you as to what kind of treatment you want to give to these patients. Now for small tumors, the best treatment options are laser photocoagulation, transpupillary thermotherapy, and cryotherapy. For medium tumors, the best are brachytherapy, chemotherapy, external beam radiotherapy. For large tumors, chemotherapy followed by local treatment and also an enucleation can be done. Then an extraocular extension and external beam radiotherapy can be done. And for metastatic disease, chemotherapy. Usually at this stage, you're more or less trying to prolong the life of the patient and by giving chemotherapy. Now for using the International Intraocular Retinoblastoma classification, these are the treatment options for these patients. Just a moment, okay? So for patients that, for the small tumors like we've talked about, you can use focal therapy for them. Just a moment, please. Okay. For the small tumors, focal therapy can be used for them. And if the focal therapy is not available, you can send to a place where you can get such treatment. Then for bigger tumors that are more than 3 millimeters, this is just like a repetition of what I've said before, focal therapy with or without systemic chemotherapy up to 6 cycles. Now for unilateral, if it's localized within 3 millimeters from the, if it's a localized tumor, okay, with vitreous or subretinal seeds that are within 3 millimeters from the tumor, for the unilateral case, you may decide to enucleate the eye. Then just even though we are talking about unilateral, but just for us to be aware that for bilateral, we can attempt to salvage the second eye. We can enucleate one and attempt to salvage the second eye using systemic chemotherapy for 6 cycles, plus or minus focal therapy. For a diffused where you have that diffuse vitreous or subretinal seeds, for unilateral eye, we would like to, it's advisable to enucleate. And as we said before, for the bilateral, an attempt to salvage the second eye. Then, okay, then for the lower part of the table shows the standard dose of the chemotherapy, which is given every 3 to 4 weeks for intraocular retinoblastoma. Then focal therapy involves the transpupillary thermotherapy, TTT, the laser photocoagulation, cryotherapy, plaque radiotherapy. It can be used alone. That's for, if it's group A, it can be used alone or after initial systemic chemotherapy in groups B to D. For the focal therapy usually works best for small tumors less than 5 millimeters or reoccurrences or a recurrent retinoblastoma without vitreous or subretinal seeds. Laser photocoagulation. This is the application of argon laser either directly on the tumor or in a ring-like fashion around it to coagulate the feeding blood vessels and to lead to, which can lead to ischemic tumor damage. And it's usually in the next 2 to 3 sessions, can have up to 2 to 3 sessions, you repeatedly cover the tumor with laser bonds. The complications of this, however, is vitreous seeding, vascular occlusions, pre-retinal fibrosis, associated retinal traction, and vitreous hemorrhage. Cryotherapy is usually done for anterior or peripheral tumors, and it involves applying sub-freezing temperatures down to -90 degrees Celsius directly to the tumor mass. This causes damage to the vascular endothelium with secondary thrombosis and infarction of the tumor. So this is how it works. So you usually use a triple freeze thaw technique, meaning you put the probe on the tumor, allow it to freeze, and then allow it to thaw, remove it, put it back again like that for 3 times in 2 sessions with a 3-weekly intervals. The complications, however, are lid edema, conjunctival chemosis, serous retinal detachment, vitreous hemorrhage, and tractional retinal detachment. For the plaque therapy, is usually for large tumors or areas of relapse and can be used for tumors with basal diameter and height less than 60 millimeters and 8 millimeters respectively. Usually, iodine and ruthenium are the radioisotopes that are used. Gold plaques carrying those radioactive seeds are sutured to the base of the tumor to provide about 40 gray of radioactive light to the tumor apex over a period of 2 to 4 days, after which the plaque is removed. The complications, like other complications of such therapy, is cataracts, radiation retinopathy or papillopathy, optic neuropathy, scleral necrosis, keratopathy. Now, enucleation, it's usually done with orbital implants, and you can also use one eye off. It's usually done in orbital implant, and it's preferred in unilateral cases that are in group D or E. However, when you have a bilateral case, you can enucleate one of the eyes. Usually, as you enucleate, you're careful enough to get not less than 10 millimeters of optic nerve, which you can measure. You can, and it's important to also look out for signs of metastasis, such as optic nerve thickening. So it means that after you enucleate the eye, after you remove the eye totally, you have to inspect. Don't just remove the eye and go away. You have to inspect. You have to look out for signs of metastasis, such as optic nerve thickening, sclera or extrascleral invasion, any nodules on the sclera, any anterior chamber seeding. And also remember after enucleation to send your sample for histology. For external beam radiation, the use of this in retinoblastoma has drastically reduced due to the increased risk of second non-ocular malignancies such as osteomas and osteosarcomas, particularly in infants under the age of 12 months who have the germline type. However, for children who have extraocular retinoblastoma in the orbit, external beam radiation will play an important role. In intravitreal chemotherapy, it has a better penetration than the systemic chemotherapy. Drugs used are mefalan, topotecan. They could either be given alone or in combination. And it's important to do an ultrasound biomicroscope or to assess the injection sites before giving. The contraindications include tumor at the site of injection, tumor extends to the tumor at the site of injection, and then there may be extension of tumor to the ciliary body. Retinal detachment and vitreous hemorrhage may also occur. Now, the way it is done is that a small diameter needle is usually used, about 30 G. Then the site of injection must be 3 millimeters from the limbus on into the pars plana. Then you do a triple freeze thaw cryotherapy at the injection site as the needle is withdrawn. So once you give the injection and you withdraw it, you do a cryotherapy. Then you jiggle the eyeball. Jiggle means to shake the eyeball with forceps to distribute the drug evenly throughout the vitreous. The dose of intravitreal mefalan is 20 to 30 micrograms for a maximum of 6 injections over 2 to 3 months, depending on the distribution and extent of vitreous seeds and response to prior injection. And it's been said that eye salvage rates have significantly improved as a result of this treatment. Then there's the intra-ophthalmic artery chemotherapy. it involves direct treatment of the eye through the intra-ophthalmic artery. Okay. Once you have tried systemic chemotherapy and focal therapies and you've not seen any improvement, this can be tried. The treatment should be used with caution as first-line treatment for the unilateral advanced groups, that's group D and E, as they may metastasize. So it's important to be cautious. Okay. Then this is just a figure that tries to summarize how the recommended protocol for retinoblastoma with extraocular extension. So if this child has extraocular extension, we can try 3 to 6 cycles of high dose chemotherapy. If there is persistent extraocular tumor component, you can continue until 9 cycles of high dose systemic chemotherapy. Now from the persistent extraocular tumor, if there is, okay, first of all, there are 3 cycles. Okay, let's go from here. Persistent extraocular tumor component, continue. If it's still persistent, you do an orbital exenteration. And from there, you can also do, after that, you need to do an orbital external beam radiotherapy. Afterwards, continue high dose systemic chemotherapy to complete a total of 12 cycles. Now, after giving your 3 to 6 cycles, your initial 3 to 6 cycles of high dose chemotherapy, if there is phthisis bulbi, that's a shrunken blind eye with regressed extraocular tumor components, you may need to do an enucleation with an implant. And also, you may also need to do an orbital external beam radiotherapy and continue the high dose systemic chemotherapy to complete a total of 12 cycles. So these are doses of the high dose chemotherapy. Usually the drugs used are vincristine, etoposide, and carboplatin that are used. Okay. Then this is also a kind of like a summary of treatment plan using an algorithm. For the unilateral, for this patient who has a unilateral group A to D, you want to do an intravenous plus or minus subconj chemotherapy times 2 doses. Then you can also do, you want to do a transpapillary chemotherapy plus chemo times 4 that's 4 doses of 4 courses of chemo every 3 to 4 weeks, plus cryo if anterior. And then you ensure that you monitor the full blood count and platelets. Then if it's a unilateral group E, these are the treatment options. You can offer enucleation as a primary treatment. If refused, you can give 6 doses of chemo and then EBR for the patient. Then this is just an addendum. If it is a bilateral disease, usually one eye is advanced and the other early, you can opt for chemo, then transpapillary chemotherapy, plus chemo every 3 to 4 weeks, plus cryo if anterior. Then examine the worst eye and enucleate if group 5 at 6 course of chemo. Then always remember that patients' full blood count and platelets have to be checked. As we've said before, avoid external beam radiation at all costs in bilateral cases, especially. Then if it's orbital disease, even in this unilateral case, you may need to do chemo 3 courses, then enucleation, and continue chemo for another 3 courses, then external beam radiation, and then give another 6 courses of chemo. Now, counseling is a very important part of the management of the patients. And in counseling, you need to intimate the family members or the caregivers about the goal of therapy. Like we said before, is it to save life? Is it to save the eye? Is it to save the vision? These things have to be clearly stated to the patient so that they understand. The process of care has to also be stated for the patient, the number of days that the patient may have to spend in the hospital, the level of care that the patient may need thereafter. Then treatment options should also be laid bare. Cost implications is very important because funds scarcity is one of the things that affects people reporting on time to the hospitals. And then scheduled follow-up care must be ensured, or people must be counseled that they have to come for their regular follow-up. And for genetic counseling, patients is very important. Patients with familial retinoblastoma have a 50% of transmitting the disease. Healthy patients with unaffected child have a 5% chance of having another with the disease. Now, if 2 or more siblings are affected, the risk of subsequent children being affected is 50%. And a survivor of hereditary retinoblastoma has almost 50% chance that his or her children will also develop the disease. So it's also important to let them know. And for follow-up, the patient is advised to come every 4 weeks during treatment, every 2 to 3 months during the first year after treatment, every 3 to 6 months until 6 or 7 years of age, then every year after that for follow-up. Differential diagnoses include cataracts, persistent fetal vasculature, toxoplasmosis, tuberous sclerosis, and the rest. In conclusion, retinoblastoma is an intraocular cancer with potentially severe clinical consequences if left untreated. The nature of laterality, that's if it's bilateral or unilateral, can affect the diagnostic and clinical management guidelines. Unilateral retinoblastoma show increased promise for survival and better quality of life compared to those arising from bilateral origin. Some of my references. Thank you for listening.
Thank you very much, Dr. Oduware, for this very enlightening presentation. Questions and comments.